Hi, Justin. Morning.
Wanapa, how are you?
Hi. Thank you for recording on this. We'd like to seek Dr. Marco permission to have it upload on the BMS platform for CME and other nurse learning credit on our site.
That is fine with me. Yeah.
Thank you so much. Hi, Marco.
Hello, everyone. Yeah, thanks for having me.
Thanks for joining us. Hi, Marissa.
Justin, and nice to meet you, Marco. I'm one of the epileptologists here at OHSU. I don't think we've met in person yet.
Oh, it's really nice to meet you. Yeah.
Thank you very much. Justin, now, can you kindly introduce the speaker for all of us?
Once again, I might pass over to Marissa. I think, Marissa, you were kind enough to invite Marco. Can we maybe start there?
Sure, yeah, and Dr. Lutzup sends her regrets for not being able to make this meeting. She is the chair of a committee, and it was Dr. Lutzup who suggested Dr. Colasurdo, who is one of our neurointerventionalists, new neurointerventionalists here at OHSU, and a stroke specialist. So yeah, without further ado, thank you, Dr. Marco, for joining us.
I can give a little bit of background also if you guys want, if that's helpful.
Sure.
Yeah, so as you were saying, I joined recently in the last year as a neurointerventional faculty here. I'm a neuroradiologist, and I worked also as a body IR doctor for some time in my country, Italy, and here in the States. And I trained formally trained in neurointerventional in Baltimore at University of Maryland, and about it. Yeah, stroke is one of the main interests, of course. It's becoming more than 50% of our practice, I would say. So if we're ready, I can try and share my screen.
Thank you very much, and thank you for joining us. Try and share again. I made sure you had privileges. You can just try again.
Sorry, just. Are you able to see it?
Yes, thank you.
All right. So I'll start this conversation with a case. And it's a case that I did here at OHSU not long ago. And this was a 86-year-old male who has the past medical history that you can see, and he basically presented with an NIH of 25, so pretty sick. And the timing is very important. So last known well was 10:40 in the morning. TNK was given at an outside hospital shortly after. He was very active, and he was off Coumadin for a minor surgery, which is a very common story that we hear when we're doing thrombectomies. This is a CT head that was performed at the outside facility, and that was 11:24, so basically an hour after the onset, roughly an hour, a little bit more. And if you look at this, the first thing we look at always is the kind of like aspect scoring, right? And if there are early signs of ischemia, and this actually looks really good for somebody who's 86-year-old. I wasn't able to find any signs of early ischemia. So the aspect was done. And we decided to, of course, he's got also a CTA that shows how is the left side ICA is out. There's no contrast there. This is the right side, and there's very poor collaterals looking at this. Right, so he's got a good profile because of the aspect, and he's got left ICA occlusion at least with minimal collaterals in the MCA territory. Now this is his neck imaging, and this is tricky because the left common carotid seems to be out, and we don't really see the ICA or so the internal carotid or the left common carotid at all on the CTA. And this is not something that we, as neurointerventionalists, we like that much, because not being able to see the common carotid usually means that there's some issues at the carotid bifurcation, and it makes the procedure much more complicated because of managing potential stenting, managing potential other potential complications with dual antiplatelets. He's supposed to be on anticoagulation, but he was not. So this just becomes much more complicated looking at the scans, right? He gets we accept him. He gets transferred, and on arrival, so at 14:49, this is his CT. And again, he's still within the early window. So I wasn't too surprised to look at the CT and because of the collaterals that were not great on the CTA. The CT did look like there were early ischemic changes, as I would say most of the MCA territory. And you can clearly see it here. There's basically a wedge of hypodensity. I can't really tell where the cortex is. And on this side, for example, it's really obvious, right? And same thing here, the basal ganglia are blurred out, and there's maybe a little bit of edema here. This ventricle looks smaller than this one. And so this is how I would segment it. If I were to show it, this is how much ischemia he would have, according to my opinion, of course. And this could be different, person to person. But he basically, his aspect was definitely lower than 5. I would say probably a 3. If I had to give him a number, maybe a 2. Right? We also do perfusion all the time. This is his perfusion. Looks like, there's a pretty big core and some penumbra. I don't know how much we can trust this, but so at this point, there's always the decision making. So he's basically 86-year-old patient with a potential complicated procedure that has a pretty extensive ischemic burden already. And now the question is, do we still do the surgery, the thrombectomy on him, or do we stop? And I guess we could go either way, but we decided to go ahead and do it, right? So we bring him in the angio suite, and he's 86, so his arch is not super easy. And you can see here, this is just a run at the arch, the left common carotid artery. I was really happy to see that it's actually open. So it's what we call pseudo occlusion, meaning that it looks like it's occluded, but probably there's just not contrast going in there. But the angle of this carotid takeoff is not super easy, and that's mostly because he's 86, and we see it all the time when people get the age. But we're able to go up, cross it with a catheter, and get all the way in the internal carotid artery, and that's the first head run that we do. This is a AP on the left side, and this is the lateral, and you can see the clot here, this kind of faint gray, and here. So it's what we would call an ICA terminus occlusion, which was much better than the tandem ICA plus ICA terminus that we were suspecting. But again, it's not straightforward. He's got this cervical loop, which can be very insidious most of the time. You can get dissections and it can become very difficult to navigate. But anyways, not in this case. We actually get a pretty big catheter. This is an aspiration catheter all the way up in the MCA, and we get the clot out with one pass. Right, so this is the post-thrombectomy. The MCA is open, all the branches are open. It's TB3, what we would call it, or functional 2C or 3. It's about the same. So what now? So we get a dual energy CT scan, which is basically a CAT scan that's able to subtract contrast, stasis, and contrast enhancement. And it shows what we were expecting. So the wedge of stroke, which is this kind of like hypodense area, is about the same, very accurate. I would say maybe smaller than what we thought, but there definitely is some swelling because the ventricle here is smaller, here smaller as well, and definitely smaller here, right? So, and I don't see the salt side on this side, well, I see them on this side. So definitely some swelling. This is the MR that we get shortly after. And the MR is very reassuring. It basically shows some cortical diffusion restriction, the basal ganglia, they most of the time they are gone before we see the patients in the ED. So that's not unexpected. And then we get another CAT scan. This is about a week to 10 days out, and it does show the infarct in the left insular temporal lobe, a little bit of frontal lobe, I think, and maybe a little bit of parietal junction and basal ganglia, of course, but no hemorrhagic transformation. And it's actually a much smaller stroke. And this patient actually did pretty well. His stroke burden was big to begin with, but you know, from day 2 he was able to move both sides without issues. He was aphasic, and he's still aphasic. Aphasia is going to be very hard for him to recover because of the involvement of the white matter in the arcuate fasciculus that crosses from Broca to Wernicke here, and that's kind of complicated to overcome. But he was not plegic and he was able to walk, which was great. So I just wanted to basically talk about large core thrombectomies a little bit, and this is kind of a case of a large core thrombectomy. And this is a very hot topic right now, and it's everybody's talking about large core thrombectomy and should we do them? Maybe we shouldn't. So I just wanted to just throw some thoughts there and see what kind of share what I think. So going back, you know, thrombectomy is 2015, and I'm sure everybody knows about this, but the big 5 trials, right? Mr. Clean, Extend IA, and Swift Rhyme, and Escape, and so on, and Revascat. They all shared 4 things, and they all shared the use of four very important variables. One is LVO, so the presence of an occlusion. And it may seem strange, but some of the other trials that were out there between 2011 and 2015 actually were randomizing people to thrombectomy without LVO demonstration, which is surprising now, right? Then they all had a way of measure stroke burden, so aspect. And this was what we had in 2015. They all wanted to look at kind of pre-stroke disability, so MRS, and they all wanted to see how bad is the patient before thrombectomy, so the NIH stroke scale. And these 5 trials showed that basically if we do the, you know, procedures, so if we do mechanical thrombectomies, these patients do much better than maximum method that we had at that time. And they did show that basically, it's interesting to look at this. This is from Mr. Clean. And I always kind of like bring this up. The mortality was very similar between those groups. And the only thing where we actually were making a difference was the disability, basically. So the morbidity for these patients, right? And some people, it's not always easy to remember all of this just because we have so many trials coming in basically every year. What happens then is that in 2018, we had 2 more trials, and these are done in the Fuse-3, right? And they look at mechanical thrombectomy and they say, you know what, we're very strict with the 6 hours from symptom onset, but what about the other patients, those that come in at 6 to 24 hours? And they randomize them and they use perfusion imaging, and basically they show that this also is effective and this improves outcomes. And this also changes mortality, which is very interesting, I think. And with these trials, we kind of like start seeing new words coming in our ward. So, and these new words are the word core, which we always substitute for infarcted tissue, and the word penumbra, which we think is tissue that we can save. And then the word mismatch, which is basically the difference. And it's kind of like what we can save. Okay, much better. And so the 4 variables that we had from 2015, they just changed a little bit, and we have a new one, which is the perfusion variable with core, penumbra, and mismatch. Now the story does not end here, because in 2022 there's and 23 there's a few other trials that came out, and this is Rescue Japan, which was basically looking at LVO within 24 hours with aspects between 3 and 5. So just the ones that were not eligible for thrombectomy, right? And then same thing, angel aspect and select 2. We're looking at roughly the same population, looking at different angles. So aspect below 5, they even have aspect of 0, and cores greater than 70, which was one of the Dawn criteria, right? So what we're effectively doing is we're just taking those 5 variables and just bringing it down to 2 variables effectively. So LVO, MRS, and NIH. And that's kind of what these trials are telling us, right? So I personally found that very interesting, and with a friend, we actually wrote a meta-analysis on this, looking at the trials, and we wrote this meta-analysis just to see, hey, is it really true that we can avoid looking at aspects and perfusion? Can we just go straight to angio most of the time if they don't have a bleed? And the numbers are great. We are actually helping a lot of patients. If you look at the MRS in 90 days, and this was kind of our end conclusion, saying that EVT is basically beneficial for anybody who presents within 6 hours, and if they have an aspect core between 3 and 5, and they have an ICA terminus or a proximal M1 occlusion. So now I'm going to try and dig a little bit deeper into this, because I think it's very interesting, and I think we fully understand it as of now, but it's nice to think about it, because it really helps with medical decision making. So the concept of looking at very low aspects is not new at all. So when those 3 trials came out, angel aspects like to everybody in the world was like, wow, this is great. I don't know why we never thought of this, but this is not true, because there are trials, and I like just got this one, but there's others. This is the PC, and they did mechanical thrombectomy for acute ischemic strokes regardless of aspect, and they had a few patients with MR aspects between 0 and 4. And if you look at the outcomes, it is actually crossing 1. So meaning that there is some benefit maybe, the confidence interval is very wide, so it's hard to say. But this was 2016, so it's a long time ago. Like it's actually 6 years before the large core trials, and these were patients within 4 to 6 hours, right? They were doing them the thrombectomies regardless of aspect, and so why are we so reluctant when we have to do mechanical thrombectomies in large core patients? One of the reasons is the concept of hemorrhage. And the concept of hemorrhage brings in another concept, which is harm. So am I gonna harm this patient if I do my mechanical thrombectomy and they have a large core stroke? And there's a lot of papers on this, like a lot. You could spend a week reading about this, maybe more weeks. And this was one of the nicest one. And this was specifically looking at the late window endovascular therapy for stroke. And they basically concluded that the risk of hemorrhage is very low. And also it doesn't really affect 90-day MRS. So this is one side of the medal. The other side of the medal is, why are we so reluctant about doing large core thrombectomies? Is because there's another concept that we should know about, and this is more about a term, and is the concept of futile recolonization. And these two terms, harm and futile recolonization, are very important when we talk about large core thrombectomies. The reason is that when we're doing N1 thrombectomies in patients who have very high aspect value, like 9 or 10, so basically almost no stroke, our potential for harm is so tiny, and the benefit is so big that anything else just we can't see, right? Even from a statistical standpoint, we just can't measure anything else. But when we're doing these large core thrombectomies, then futile recolonizations actually come out really a lot. And are you guys still seeing the screen? There's something changed on my end.
It dropped out actually. Can you reshare it again?
Yeah, I'm trying. You see it?
Yep, it's back now. Thank you.
All right, sorry about that. I don't know what happened. So so futile recolonization is very common when we're doing large strokes, and it means that I think it dropped again.
Yeah, that's bizarre.
It's very strange. One more time.
Happens again, and you want to email that to me, Marissa Kellogg, or
Mm-hmm.
the email.
So you guys can see it, right? Let's try again. So basically, it's actually very common to have a vessel that is open on a large core, but very poor 90-day MRS. And that's what futile recolonization means. So I do everything that I can. It actually goes really well, but the patient still does poorly from a clinical standpoint, because we don't really treat pictures, right? We treat patients, and we should aim for them to be better. We should look for outcomes, right? And that's where this is also a very interesting point, and there are a few things that can be done. One of the things that I worked with a couple colleagues is a score to predict who's going to do bad regardless of a successful thrombectomy, right? And we came up with a scoring. This is actually a new one. It's not part of this paper, but it's a part of another paper that's coming out. And basically, if you look at this, the important variables that came out were baseline disability, and this is part of what we use. Age, which is surprising, which is not part of what we normally use. NIH stroke scale, which is part of how we select patients, very important. Aspect, which we use for a very long time. and I think it's still pretty effective, and delay from last known well, so 6 hours or more. And we used to use this one for a very long time, and then we stopped with dawn and diffuse 3. And I just found this very interesting that these variables came up with the with the successful thrombectomy, but not great outcomes. So now going back to the large core trials, right? This is a table in the meta-analysis that we published that basically looks at the trials. And I just want to quickly go through some of the things so that I find interesting. So everybody was looking at internal carotid artery or M1 occlusions, except for LAST, which also looked at M2. The number of M2 is so small that I don't think we can draw any conclusions. So when we're talking about large core trials, we should focus on internal carotid artery or M1 occlusions, and we can't really say anything about any other vessel. That's one of the main points that we should have very clear in mind if we're ever doing a large core thrombectomy. And then I want to look at the time, right? So rescue Japan up to 6 hours, Tenjin and Lasti basically 12 and 7 hours, right? Now, Select 2 looked at patients up to 24 hours, but if we look at the data, they were actually looking up to like their median time was actually less than 10. So we're probably within the 12 hours most of the time. Most of the patients were within 12 hours. Angel aspect was very, very similar. They were probably even shorter than that. They were like, most of their patients were actually within a 6-hour window. And I personally found this very interesting. The only trial who actually had patients up to 24 hours, and a good number of them, is Tesla. And this is a chart from the meta-analysis that we published. And if you look at this and you look at Tesla, right, MRS 0 to 2, MRS shift, and utility weighted MRS, and so on. Tesla is the only one that actually kind of like barely failed as a trial. And I personally think that most of the reason is that they actually included patients up to 24 hours for real. So they had a lot of patients which were in the late window, and when you're in the late window and you have a large core, you're probably not going to do well. And that's very important to remember if we're doing large core thrombectomies. So few papers came out late in the last couple months. This is on kind of a commentary on JNIS. Should we do it? Should we not do it? And then the kind of the same group comes up with new updated guidelines for endovascular therapy in large vessel occlusion with large core and also basilar, which is not the topic today. But they basically say that everybody with an anterior circulation, which I don't think is what we should say, because we should limit this to M1 and ICA, who presents within 24 hours or last known well or large core, and meets the criteria for these studies, they should get thrombectomized. Now, this is, I think, probably an aggressive statement, basically saying that we should thrombectomize anybody who comes through the doors. I just wanted to throw out a few other ideas. So I always like to take a step back and think about our past, like we did before with the trials. So we know that patients that have strokes have limited time before they actually get infarct, right? And neuronal death. So, and we started using neuroimaging to kind of like have an idea of how much tissue they lost already and how much we can save. And the easy way that we thought to do it the very first time was just to get non-conscious CT and look at how much hypodensity and stroke there was already, and then somebody came up with aspects, right? The Alberta scoring. And everybody started using it because it was very easy to use and quick, and it was a good way to communicate, I think. And it worked really well. So aspect, I think, is important. Then what happened? Historically, we had quantitative analysis, and we became fancier basically. We started doing CTP, CT perfusion, MR perfusion, and we started using terms like ischemic core and penumbra. And we then started using AI to implement CTP and make it more feasible, right? In clinical routine. And here we have our CTP, right? And these were like both aspect and perfusion, especially perfusion, were very much used and probably abused when we look at the last trials that we looked at, like Dawn, Diffuse J, Wake Up, and so on. But why? Like we should stop and ask, why is this? So therapy and thrombectomy in acute stroke is predicated on one concept that basically when we open the vessel that's occluded, this is not always successful. Not all the patients that we open up do well. And some of them may hemorrhage and some of them may die because of the procedures. And being too aggressive with these treatments, especially when patients have larger cores or smaller penumbras, may actually expose patients to excess harms or risks and minimal benefit. And this is kind of what led the Dawn and Diffuse Tree trials, right? And all of this comes from one study, which is very, very interesting. This study from Astrup. And this study, it's like from 1977. It's very old, like 50 plus years old. This study looked at monkeys and they looked at how and they come up with the umbra penumbra dogma, which is basically core and penumbra. But we're looking at this study from 1977. We're pushing it to CTP, and CTP is being used in a different way than it was devised for, because CTP was devised for prognosis stratification. So I would do CTP and say, hey, this patient has a chance of recovery, this patient maybe does not, but not for treatment decisions. And I think that the concept that Astrup brought up in that paper actually is generally true, but can't be generalized like we're doing today, right? So what I think our conclusion should be is that, and this is what it's a very important point, I think. So higher rates of poor outcomes in the EBT arm are extremely evident in the large core trials. So about 80% of the patients that were in those trials are either deaf or have a high disability. And I think I lost it again for some reason. We're very close to the end, so I'll just try and share it again.
Keep trying. Yeah, sorry for this.
Oh, it's okay. Yeah, sorry. So so basically a lot of people actually do very bad. And so just doing thrombectomy every one, just because we know there's a tiny percentage of patients that benefit, is probably a very crude strategy, I think. What we should learn from these trials is that if we reperfuse ischemic core, which we thought was infarcted, we probably have some benefit clinically. And I think this is the important point. And we should strive to get better imaging tools to select patients rather than just thrombectomizing everyone. My take on the large core is, I think location is going to be very important. So ICA or M1, if you're doing a large core ever, think about the location, think about the MRS, so how much, and also age, because age is going to come up as an important variable in large core thrombectomies. And then above everything else, I would think about time, because I think the 6-hour mark and time frame comes up all the time in studies that have been going on for the last 10 years, and it's probably a very very true that's an important time point in acute stroke. So if you ever want to do a large cord thrombectomy patient, I would think about these things, because this is what the trials have been showing so far. And for those of you who are interested, some of these thoughts are also summarized in this paper that came out recently. And that's it. Thank you for listening.
Thank you very much. Doctor from BDMS, any question for Dr. Kolusoda? Ajahn Chanpong, any question from you? Dr. Chanpong, can you hear me? You have any question?
Try to open the mic, okay? Thank you so much, Dr. Marco. I learned a lot from your study under this case, that I wonder whether you can open the vessel of the ICA occlusion and a very big core. So lastly, you did the job very well. May I ask you one question from the sixth trial of the large core, as you showed me in the picture. How about the latte, the last one from Europe and United States? That the aspect score very low, 0. How could in the old day, I think that aspect score 0, maybe you have the death bed already on the big infarction. How could I explain that if you have the really big core, like more than 70 cc? What is the new theory that mean that the death bed is not really dead, is right? Thank you.
Yeah, so I think this is a great question. And before writing the AJNR editorial that I just showed, I, with a group of friends that we talk about this all the time, and I think when they say aspect of 0, it's probably not a true 0, and I think we really poorly understand the concept of stroke. So this comes from two things. One is, I think there's a little bit of aspect, CT aspect of reversal, meaning that you could have some changes on CT, very early changes on CT, that may not be there afterwards. And that's one thing. The other thing is that sometimes we would give an aspect of, 2 or 1 or 0 to a patient just because we don't see the cortex. And this is actually very important. Like if I can show my presentation again, and I can show this patient. So this patient, for example, the one that we saw, right?
Yes.
His aspect is, looking at this, I would say this is really bad, right? But if I look at the MR, it's mostly the cortex, right? The white matter is involved, but not that much. And the way that I look at this is, let's say that my cortex is my cell phone, and the white matter is my receiving tower, where all the cell phones go through, right? If I lose my cell phone, but I have my receiving tower, I can use another cell phone. So let's say this cortex right here, to call through the receiving tower and use the function. But if I lose my receiving tower, even if I have all the cell phones in the world, there's no way I can get through. And I think that's part of what, even if I have a very large ischemia, I may be able to use what's left of my cortex, what's left of my neurons, to do some of the functions. And this, I was surprised this patient was walking and moving everything normally, right? And if I haven't seen the large core, I might not have done him to begin with, because his CT head was not looking great. I think this was basically almost a good infarct looking at this. So I just think that sometimes when we say it's 0, it's probably not 0. It's probably 3 or 4, or maybe 1. The problem is, I don't know who is 1, who is 0, who's 4. So, and it's hard. So I think we need better tools to select patients. And I think one of the tools is actually a very efficient, low cost tool that everybody has, which is time. If they're within 6 hours, they are probably not going to be at 0. They're probably more like a 4, but we see them as a 0, but they're probably not. And it's like a very simple technology. Time has worked so well for us. That's kind of my take.
Thank you.
Yeah.
Another question, may I ask you, because in BHQ, we use MRI based for mismatch, not CT based. So how is equivalent between MR aspect and CT aspect? I mean, most of the time we use MRI for detect the patient with mismatch. Do you think MR aspect and CT aspect is the same? Can be equivalent?
Yeah, so that's a great question. So I think from what I've read and what I've seen, so MR is it's very powerful, right? With MR, I think we risk overestimating ischemia.
Yeah.
So with MR, I would actually push it even further out because most of the trials are with CT. Very few actually use MR. Only the French trials use MR. They actually have very high MR usage. So, and I think with CT, we see it growth less. With MR, we see it much more. So with MR, I would push it even further out. And I would be even more aggressive with MR-based imaging. Both MRP and just regular MR with mismatch between FLAIR and BWI, regardless of how you do it, I would be much more aggressive.
Okay. Thank you.
Yeah.
Thank you, Dr. Chanpong. Any question from anyone for the speaker?
A quick question. The age data is interesting. What is your general approach now? Is there an age at which you don't generally intervene unless something looks really promising, or how have you incorporated that age prognosis data into your practice?
So the way that I look at age is for large cores. So when we did the meta-analysis, age was almost significant as a predictor for worse outcomes in large cores, and the age that was the tipping point was 75, but it was not significant. Like it was almost significant because there's not a lot of patients in those trials that are actually older than 75. So we would need more patients to actually get significance. But in my practice, I personally go around 75. This patient was 86, right? And I personally did it because he was a very fit 86-year-old. He was basically like muscularly like a 50-year-old when I looked at him. But if I were to be strict, my criteria for large core thrombectomy would be age 75, 6 hours, and ICA or M1 occlusion. Very strict. And I think if we use this, the patient will do much better than what the trials have been showing.
Thank you.
Yeah.
Samitivet.
Just would like to ask the questions that follow Dr. Melissa now. Because of the aging seem to be related with the cholesterol and the stenosis now that quite maybe the cause that cause the large infarction. So I think that if it benefit if we change such as the age to be like a functional age, such as the parameters such as the risk factor for cardiovascular risk, something that it should be more specific, right? I think that it should be more better as we saw many people when aging, they look even younger, very younger than another one, such as you may look like 50 people to be 30 people I think this one we use age, and age is quite maybe mislead the decision also. Thank you.
Yeah, no, I think I don't know if I understood everything correctly. But I think you're right. So looking at somebody and saying, hey, like they look younger, I still want to do it. It's probably not the right way to go. But this specific patient went from an aspect of 10 to an aspect of 2 within 3 hours. And I don't see that to be that possible. I highly suspect that we were overestimating the second aspect. And the MR shows that we were overestimating, because basically the white matter was great. Like it was not infarcted at all. And even the cortex that looked like it was infarcted, it was not infarcted after the thrombectomy. So again, part of it is aspect reversal, part of it is us just overestimating. And I think time is very important. Time is extremely important in these cases.
Such as in this case at the first line, we saw so many cardiac problem, post CABG, some things and even DVT or some things many. So 80 years old with this underlying, it seems to be much more, much more risk, much more low cholesterol or P number than 8, like 80 with healthy condition. ครับ thank you นะครับ in fact I have one more questions quite questions about the, because of I see that it's very interesting to see the difference in culture, no? That the treatment seem to be like looking forward and explore the new boundary of the treatment to find the new borderline treatment, that it seems like a treatment that done in OSU like seem to follow the updated trial, no need to wait for issue the guideline, right? This is like because of it, when we have a different in settings or culture, such as in our hospital, we prefer to wait for like AHA guideline to issue the recommendation before. So I quite question that how did you do it? Are the procedure planned to do as a research studies, or having the committee that around this to do? So like this, because of we, such as when trial come out, such as we want to implement tinectibase to be injected in acute stroke, or use in like early deteriorate after admission. We still in question that we want to wait it for guideline for safety in a legal issue. Thank you. So the question is about the culture and how to do, how you proceed the procedure.
Yeah, I don't know if I understood everything correctly, but so I think it's different here, the culture. And I come from another country as well, not from the States. So I'm from Italy. I've just been here, a few years now. And the culture about like pushing the boundaries for treatment is very different, I think, where I've been. Here it's easier maybe. In my country, it would be a little harder to push this because it would not be guidelines driven. On the other hand, I think as physicians, sometimes we can bend some of the, rules. Like aspects is something that I could play with, and I could say this is a 5 or a 6. Nobody can say it's not, because aspect is known to be one of those things that I could show it to 20 people and get 20, not 20 because it's like only 10, but like get many different answers, right? And I guess that's one of the ways that we would do it in my country. we would say, hey, this looks like a 6 to me, and we would just do it because I think this patient benefited from the treatment a lot. Because he's not in a bedridden and he needs like constant attention all the time right now, which is a great result. But here, I think there's a push since those large cohort trials came out, there's I would say a push to try and get that line of treatment like very close to that line, and trying to treat as many patients as possible that could benefit from thrombectomy. And I think the main worry is that we don't want to lose anybody that we could potentially save from permanent disability, which I think is awful as a result. So I agree, it's a cultural difference, and some places are really strict with guidelines, like my country, and from what I understood, maybe yours as well. But here it's a little bit different, and we need a little bit of both, I think. Not too strict, not too loose, but somewhere in between, maybe.
I just want to highlight that's an extremely perceptive question. And one thing that I, having had the privilege to travel to visit, you in Thailand, your practice seems to be very data driven and evidence based, which is amazing and has a lot of advantages. You therefore do less unnecessary care like we do here in the United States. So, but yeah, also we can push the envelope culturally a little bit more. But I love that suggestion of how the more subjective aspects, no pun intended, can be used to your advantage.
Thank you. BKS Payathai to Smritivet, any question from you for the speaker? Any other question for the Dr. Marco? If not, Justin, Dr. Marco, Marisa, thank you very, very much for this comprehensive talk, and we will share with other team member, upload to the learning platform as well. Thank you very much.
Thanks, everybody. Thank you so much.
Great
Thanks,
day.
Marco.
Thanks, everyone.
Thank you.
Oh, I'm sorry I didn't get to hear the whole thing. I'm gonna catch it another time. This is Helmi.
Thanks for joining.
Thank you, Dr. Lucep. Thank you.
Great.